From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech.
Good morning, or good afternoon, or good evening, depending on where you're watching. I am Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen, and it is my pleasure to welcome in Christopher Northam. Welcome, Christopher.
Good morning. How are you, Jeff?
I am doing well, thank you. Christopher is a wonderful guest, and my pleasure to introduce him. Christopher is the former head of enterprise telehealth at HCA. And now has a consulting practice focused on healthcare strategy and operations. And Christopher really has a fascinating and unique background. Christopher began his career in healthcare in the military, and I'd love to chat with you more about that in terms of what that involves. And thank you for your service. You served as an active duty officer for many years in the Army Medical Service Corps. And in the areas of healthcare operations and logistics. And I understand you had assignments in the 82nd Airborne, the 3rd Infantry Division, and the Pentagon. And after that, you moved over to Humana. Christopher led the Technology Procurement Group and went on to establish the Clinical Innovation Division, which is going to be the really crux of what we're talking about here today. Christopher then moved over to HCA, where he went on to establish and lead the enterprise telehealth service line. And after nearly 9 years at HCA, he spent a brief time at Wellvana, where he worked on value-based clinic acquisitions. So welcome, Christopher.
Hey, thanks, Jeff. I appreciate it. Glad to be here.
So tell me, as we've talked, the subtitle of the show is Conversation with Friends. So one of the things I like to get at is what led you to get into healthcare, or is that simply a matter of where you ended up with your Army assignment?
Yeah. So actually, I started out Navy. I think you know that, but for the others, I started out as a Navy corpsman, enlisted after high school. And Navy corpsman is a medic. And so I went into the medical field and was assigned to the 2nd Marine Division at Camp Lejeune and got to work in the field with the Marines a lot as their corpsman. And it really led me to have a desire to develop further in the medical field and really to continue to grow, which allowed me the opportunity when I went to college at University of Kentucky and went through the Army ROTC program. I decided to become a medical service corps officer and continue my career in healthcare.
And you were following, there's a long history of family service. Your dad was in the service as well, and your son is serving now. So long history of family service.
Yes, sir. Yeah, I'm grateful and proud that we've got a large group of us that have served and are preparing to serve. So it's an honor.
Well, we all thank you, and it's because of folks like you that we can do what we do. So thank you very much. Tell me a little bit. I'm just curious. We hear things like the 82nd Airborne and 3rd Infantry. Obviously, everyone knows what the Pentagon is. But talk to some of those who are a little bit less informed, like myself. What's the 82nd Airborne? Obviously, people hear about it, but what does that entail? What's the 3rd Infantry?
Sure.
What does that mean?
Well, if I can take a step back even a little bit further from that, when I first came in, really core telehealth in 97 when I was assigned as a 2nd lieutenant at Fort Detrick. And I had the opportunity to be assigned to TATRIC, which is an organization, Telemedicine and Advanced Technology Research Center. And it's the Army's think tank and innovation center. It's a center of excellence. And it works with the other branches to establish technologies and capabilities for use in far forward and obviously in kinetic environments, battlefields, and so forth. So I was grateful that I was assigned there and got a year to work on a number of different programs. And the first one was in the space of behavioral health. And I do have a behavioral health background. And I loved being able to develop a program with my team that supported our Bosnia. So as we had troops and allies assigned in Bosnia during that time, we were able to provide them psychiatry far forward. Instead of having to send a bunch of psychiatrists to Bosnia, we were able to do that. That was one of the first telepsychiatry programs that I'm aware of. And we did that with some of our partners out of Miniger Clinic in Kansas. And really after that, it just kind of caught fire. I loved being able to work on programs that were immersive and that had a deliberate result. And I was grateful to work there. And I went on to the 82nd, to your point. I worked in less of an innovation space and more of a tactical space. The 18th Airborne Corps, 82nd Airborne Division has a 18-hour no notice worldwide response requirement. So they're paratroopers. Everyone assigned to the 82nd is a paratrooper. And so it's an amazing place. Everyone is always prepared to be ready to be called up and be sent somewhere. And I got to work as the division medical supply officer and later as the division medical logistics officer, making sure that all the medical supplies, set kits, outfits, vaccines, you name it, were ready to be loaded on planes and to be dropped into wherever our troops needed to be sent.
That is really has to be both a high pressure and an incredible experience.
It was. The 82nd it's the most unique organization that I've ever served as a part of. It was really more focused on the people than the equipment. And lots of other organizations, it feels more balanced between people and equipment. There it was over-indexed on the people. The people were really the tip of the spear.
Huh. That's really interesting. So one of the things, we've talked about was really the difference between kind of innovation that happens and intentional innovation. And our focus here is going to be on intentional innovation in providers and payers. And talk to me about that and, how you get the team focused on the same set of goals and guidelines and solving the right problems. So can you define for us what intentional innovation is and then how you start to make that happen?
Sure. It does tie back. My work in the space in the private sector ties back to my military time and being able to establish that common operating picture. So what are you solving for? And then what are those lines of effort, right? And lots of people say it in different ways, but everything can't be a priority. So being able to ensure that you're establishing that common operating picture, what are we solving for? And then focusing on what's that business case, from a finance standpoint, how are we going to ensure that our resources, both our human capital and our other investments, are going to be applied in the right areas to get the right results? And so, really that comes back to what I still refer to as those lines of effort. And those might be 3 to 5 areas of disciplined approach where you're focused on outcomes that are well defined so that you can ensure that we're not just innovating for innovation's sake, which there's a place for that, but generally it's, not in the provider or the payer space. Those are more in those defined research areas.
And how did you start to, we talked about, what's called OKR, objectives and key results. And to get to there, you have to, take a larger set of ideas and goals and get to that 3 to 5. How did you help narrow that down to get to those 3 to 5 objectives and then to really those results that you really wanted to see? What were some of the processes you followed?
I think that alignment across leadership and the teams is one of the most critical things. And that's I think a common theme that you probably deal with regularly is being able to ensure that we're working in the same direction. So being able to have those other areas that you support in an organization or that are supporting your team, being able to work in alignment and have those, as you said, those clear objectives, and that we're all looking at those key results and measuring that data to ensure that we are achieving the things that we set out to achieve, or adjusting based on if we're not achieving those.
So would you say, from your experience, you've obviously got experience in a payer, and then you've got experience at HCA and a provider. Did you notice any differences in terms of either hierarchy or decision-making process, and maybe compare that to the military if you could?
Yeah, great question. I would say that the military, if I look at kind of the immediacy of the situation, the military would be that tier 1, and I would put HCA as tier 2, and then Humana as tier 3. And the reason I say that is that's, in my mind, the immediacy to the patient, and being able to build programs that have an impact or touch on, primarily touch on the people that are delivering care to those patients. And so military, those programs are developed absolutely for the caregiver on the battlefield to provide that care to the patient soldier. And as we move to HCA, it's oftentimes that physician, provider, ancillary support, and then further back with Humana and being able to provide support to those providers and those patients who are really members, and being able to make sure that there's a structure in place for what right looks like.
And would you say because of that, that had an impact on the decision-making process or on the process you went through to narrow down those objectives?
Yeah, I would say that pretty frequently, I think I've observed, kind of the good and the bad. And the good is where you're consistently in the military. We've got an OODA loop, which is observe, orient, decide, and act, and it's iterative, so it's a continuous feedback loop. And I've seen some programs that haven't been successful that don't have discipline to follow that. So they say, okay, we're going to chart this course to achieve this objective, and we're going to be so deliberate about that we're just going to continue to force on, instead of continuously reassess and say, are we on the right track? What are we learning? What can we apply? Is there a way for us to accelerate? Are we too burdened with other matters that are insignificant?
So kind of walk me through, it almost sounds like what you're saying is some groups as they try to innovate, they try to brute force it. And help me with, now, just because you mentioned the OODA loop, and I was not familiar with it, but, you said observe, orient, design, and act. Can you walk us through the steps? And, my understanding is it's designed to be agile and iterative. And that's the part I think that's key here, that you're talking about kind of going through and bringing in the feedback as opposed to brute forcing it. And can you talk about, how that worked, maybe either at Humana or at HCA?
Sure. One of the things that I think that the military tries to do, and other organizations have tried to adapt the same style when they build strategy and operational tools, is to make them simple. Things that everyone, common language that everyone can understand, and that, in the military, you fall back to your training in a environment where there's a lot of chaos and adversity. And it's kind of the same in business, I think, is that, you stay with those core things. And so from observe, orient, decide, and act, I would tell you that HCA is, I think, a really good example of that. Observe, you're observing the problem, you're orienting to that problem to determine what resources do I have? What key stakeholders do I need to engage in order to ensure that I'm going to gain the support or the insights and the partnership from them? And then decide. And that really does come down to having scrutiny about, we can't do everything. So what are going to be those key objectives that we focus on? And then act. And really that's an execution. And I think that HCA is an operating organization. Once they know where we're going, what we're doing, they move out in a really effective way. And then they continue to maintain, they use data, and they use that a lot of feedback from the teams and from the patients to make sure, are we on the right course? Are we solving for the right things? Are we doing it in the most effective way? And is that an agile process so that it's not so rigid that we can't adjust it as healthcare changes? And I think that we've all seen that, healthcare continues to change more
Yes.
rapidly in the days after COVID-19. I think that many of us that were in the health transformation or innovation space for the decades leading up to COVID saw a very slow march towards progress. And I think COVID really allowed an acceleration, certainly during COVID. And some of that has sustained, right? Some of it has reverted back to what it previously was. A lot of in-office visits or in-hospital visits that were adapted during a time when we needed to adapt. But I would say that we continue to innovate at a faster rate in healthcare now as a result of our learnings, our key learnings, and that it was a universal experience, right? It wasn't an isolated experience. Oh, well, this hospital system or this practice learned this or that. It was an immersive learning opportunity for all of us. And I think a lot of us took a lot of that in how we develop strategies and execute those strategies today.
One of the experiences or maybe things that came out of COVID was that so many people were trying to move care out of the hospitals to keep people safe, that there were a lot of health tech things that were getting funded, getting significant funding, that were a solution to a problem that didn't need to be solved. And you and I have talked about the idea is focusing in on what is the problem that needs to be solved. And, that's the kind of a difference between intentional innovation. So how did you, work with either some of your vendors or even the people internally to make sure that you were actually doing something that needed to be solved and not creating a product just to create a product?
We had, I'm going to call out InTouch, who's now part of Teladoc, and the leadership. We had worked together over the previous, I guess, 5 or 6 years leading up to COVID, and had established a foundation of partnership, right? They were certainly a vendor, but they were far more than a vendor. They're a solution partner. And being that solution partner, they really sought to understand us as the customer so that they were able to help us solve problems. And we really did rely on them to be able to rapidly solve problems. During COVID, when we expanded so rapidly across our hospital programs, we were able to do so because we had a partner that all of the platforms, all of those endpoints for in-hospital telehealth or in-clinic telehealth, we were able to scale those rapidly. We turned on thousands of iPads, which we, adapted in the moment to be able to create isolation rooms, or to have expansion of ICU rounding, or, any number of other programs, because we had a partner who wasn't solely focused on, well, this is what I sell and this is how I deliver it and this is how you're going to have to take it. They really had those, 5, 6 years prior to showing that they were an adaptable partner. They sought to understand our strategy. They gave us insights from the industry that maybe we were isolated from, that we could apply. Having amazing solution partners really, I think, is what so many large organizations underappreciate when bad things happen, right? Is how can I turn to organizations to expand, to augment my capabilities rapidly? And have I done the groundwork in advance to make sure that we can rely on one another and that it's mutually beneficial? And then ultimately it solves the problems, as you said, that are the most paramount.
Can you, along those lines, and we have talked about InTouch, can you relay this story to me about, I believe you had realized that you needed to cut some budget figures, and you worked with them and what they did in response. And I believe it was an hours long meeting, not an hour, but several hours meeting
Yeah.
that you referred to. And can you talk about that a little bit and relay that story to the audience?
Sure. I hope my good friend Andy Puterbaugh won't mind that. When I joined HCA, and I had worked with InTouch previously when I was at Humana, but to your point, when we did the business case to scale enterprise telehealth across, at the time, 300 plus hospitals across HCA, we quickly realized that the end point, that those carts were going to be prohibitively expensive for us to be able to scale, to put them in each of the ERs, to be able to have telestroke programs, telepsychiatry programs, other multi-specialty programs, and then also in the ICUs and so forth, so that we were not going to be able to scale at the efficiency that we needed to be able to scale. So to your point on a little bit of that background, after we conducted that analysis in early 2015, I called Andy, who was the general manager of InTouch, and said, "Hey, I regret to let you know that we're not going to be able to continue this. This is it's an amazing platform that you have, and we're very satisfied with it. Unfortunately, it's prohibitively expensive, and we're not going to be able to scale." And Andy and I talked for a couple of minutes, and he said, "Hey, could you make some time for me later this week? And I'd like to fly in from California and sit down with you and really better understand the problem and the price points." And it really, Jeff, it was so authentic because it wasn't a negotiation. It was really a partner who we had worked with seeking to understand, hey, we're at this crossroad. Is it appropriate for us to stop working together or stop expanding together? Or is there an opportunity for us to continue to expand together? And fortunately, that meeting between Andy and I resulted in being able to have some co-development agreements, most of which we allowed the intellectual property that we developed together to just pass straight through to InTouch, so that they had key learnings that they were able to accelerate a lot of their business while accelerating our business, reducing our cost, expanding our footprint, and delivering more care to more patients where they needed it in those acute settings.
And the co-development agreements, as I understand it, allowed you to accelerate faster on your end without having to belabor the point, pardon the expression, with your attorneys about intellectual property, but allow them on the other end. So you're giving up something for them, to them, giving them the intellectual property, allowing them to move forward with it. So, and on the other end, they're allowing you to accelerate faster and move faster together. So it was a symbiotic process.
Absolutely. And there is no way that we would have been able to do that internally or with another vendor. That it really did work to the greatest effect for both organizations and then for our patients, which again, at the end of the day, when we talk about those telestroke programs, which really started as the cornerstone for all the hospitals across HCA, being able to, in 3 minutes, have a physician accept that they were going to be seeing a patient within the next 15 minutes inside an emergency room, that they were going to be doing that wet read of the CT scan to determine, is TPA necessary, what's the appropriate treatment for that patient. So, I mean, it's life-changing for patients. And that really was, they, InTouch, understood the impact that they could help HCA have. And as a result of that, they were really all in. And so, I mean, it's an organization that's founded. And I think a lot of that comes back to, you and I have talked about this over coffee a couple of times, but the mission and margin balance, right? And is your mission, are your values aligned with making sure that if you do good, you do good, right? Ultimately, I think that's a big philosophy that needs to be consistently reinforced across businesses, is that as we do better, we need to not lose sight of the fact that in healthcare, it's a patient-centric environment, and we need to not lose sight of the fact that those are not ones and zeros; they're moms and dads, sons and daughters.
And how, as you're doing that, how do you make sure that what you're doing is aligned with the strategic, how do you make sure that that innovation, that intentional innovation, is aligned with the strategic mission and the financial mission of the organization?
Yeah. And I think a lot of that does come back to those key stakeholders, making sure that there is solid alignment between those organizational key stakeholders in the clinical space, right? I'm not a clinician. However, I developed clinical protocols and standards of care with clinicians to make sure that we were delivering telehealth at or above the same standard as an in-person encounter. And then we measure against that to ensure that that's not just something nifty that we say, that we're actually doing that, and that we can oftentimes show that we're doing so at a lower cost, at a faster, speed to care. So there's lots of win-wins on that, but being disciplined around that and not assuming that just because you understand finance or clinical that you make a good proxy for that. Having those right partners is critically important.
And how early did you bring those folks in?
Very early. I will tell you that at the time that I joined HCA, Dr. John Perlin was our chief medical officer for HCA. And Dr. John Perlin and his associate, Dr. Ravi Chari, they, from a key engagement standpoint, they did video teleconferences with me across the enterprise to engage and solicit feedback and really educate our providers and our operators across where we thought that telehealth could go and the advantages that it would have for our patients. And so it wasn't me as a technology and business leader saying this. It was the three of us together really both soliciting that feedback and providing input, and then being able to give regular updates on the progress that we're making, some of the challenges that we're encountering, opportunities for more education, both patient and provider education. So I feel very fortunate that I've had great partners at both Humana and HCA who really understood that in order to do that, in order to succeed in innovation, healthcare innovation, that you really have to have strong teams.
And what did you do, or how did you handle? There's invariably a person or a department that may be a roadblock. And was it a question of trying to win them over or trying to go around them?
Win them over first and foremost, and sometimes go around them. So, collaboration.
And how did you make that? What distinguished between when you did which?
Oftentimes, I can tell you that my experience with IT, sometimes IT likes to be in the driver's seat instead of co-developing, and so that core IT team initially at HCA said, "Hey, we just need your requirements and we'll solve for that." And it was like, "No, that really, I'm here to collaborate with you." And, it took multiple rounds for them to understand that if they didn't want to collaborate, then they would be marginalized and we would go solve for it with outside vendors and consultants rather than using our core team. And so they came around. And it wasn't threatening. It was just like, you're not getting this. Like, it may work well for an EMR to say, "Hey, just give us your requirements and we'll go to this RFP and we'll come back with the top 3 recommendations and we'll do a bake-off and so forth." But in developing care for patients through the use of telehealth, we knew that it wasn't going to work the same way. Somebody else wasn't, and IT wasn't going to solve the problem. It was going to be a cohort of IT and finance and clinical. And fortunately that worked well, continues to work well at HCA.
And you talked about finance, the CFO's favorite, 3 letters, ROI. Can you talk about, how you helped them in terms of measuring both the tangible and intangible ROI?
Yeah, I think that the intangible, to your point, the increasing shareholder wealth as a publicly traded company and for the care and improvement of all human life, which is the mission of HCA, is that mission margin balance. And so I think that that DNA is very strong at HCA to seek to enforce that balance on a continuous basis and not have it be overweighted one side or the other. But oftentimes it really came down to standardizing the data, and our finance teams really did a great job on working with us to bump clinical data sets and financial data sets up so that we could have something that really, are we solving for the problem? Are we doing so in a financially disciplined way that is proving out that return on investment and having the outcomes, those clinical outcomes that we need, that we desire for those patients?
Interesting. And is there, in your experience, you mentioned InTouch, with InTouch and others, are there things that people either throw in that you find superfluous or leave out that you find necessary?
Can you elaborate on maybe your question a little bit, Jeff?
Oftentimes, the situation I've seen is, health techs will throw in case studies that may be relevant to one party, but it's completely irrelevant to somebody else. So maybe they'll do a case study with XYZ provider, but it's completely irrelevant with HCA, and they'll use that to prove out their ROI, but it doesn't apply. On the other side, maybe they're leaving something out that's fairly easy to capture that might be helpful with HCA.
Yeah. I think that having had a logistics and procurement background and an innovation background, I feel that I've been fortunate that I can have a lot of those conversations up front with those vendors that are going to evolve to be those solution partners, to be able to say, hey, I don't need your outside sales team visiting my hospitals and going in to try to sell against me. Let's work together, and let's, where we have justification to be able to expand, deploy, purchase more, have growth, that we'll do that together in an intentional way. And so I feel like early on that in those conversations, they quickly realized that maybe some of the tools that they're accustomed to using with other customers maybe wouldn't work at an organization like Humana or an organization like HCA, which are such scaled organizations.
Mm-hmm. Can you, I guess what I'm trying to get at is what were some of those tools, that as a provider or as a payer you found most effective to look at?
Yeah, I would say that we developed most of our own tools because we weren't necessarily just buying off the shelf. I mean, there are certainly things that we did buy off the shelf, but oftentimes, as is in the case with so many large hospital systems and payers, that they say, but we're unique, we're different, we need to modify this, do this, and without undermining the solution, but really enhancing it and being able to develop those clinical data sets to ensure that we, whether we're looking at speed to care, whether we're looking at outcomes, readmission rates, whatever those areas that we were measuring against, being able to do so in a way that was HCA or Humana centric, instead of just saying, well, Mayo did it or Cleveland Clinic did it, so we'll be able to replicate that. The systems are so different from one another, in my experience, that oftentimes, it might be directionally accurate, but it is not specifically accurate to be able to say, okay, well, if it solves that problem for them, it'll solve it for us.
Yeah, I think that's a great way of putting it. I think that's maybe what I was trying to get at, is there are things ranging from little nuances to big differences that almost every system is different and customized in some way. So that's why sometimes the case studies and other things don't apply.
Yes, sir.
And I think this may be getting at the same question. So if it is, just, feel free to refer to the previous discussion. But you mentioned that everything must be tied to the budget, either, a capital budget or an operational budget. Have we covered that, or are there other things that you wanted to mention there?
I do think that there is that balance, and I experienced it at both. Well, really at military, Humana, and HCA, is maintaining enough of a discipline around the communication about why we're innovating, and ensuring that no one thinks that it's innovation for innovation's sake. It's not a skunk work. It's not, somebody's place to tinker. It really is. We're solving for these things. We're a professional and disciplined organization. We're aligned with the entire organization and strategy of the organization. We just happen to be looking at how can we adjust, transform, innovate, improve, and being able to ensure that, that your internal marketing, if you will, is number one, solid, and number two, supported by the data. And it really, I think, comes back to, you can tell a great story and people will be like, well, that's amazing. When we have that capability, we will, be able to do all these other things. However, if you don't back it up with the evidence, and you don't, and share when there's challenges, right? When you hit those headwinds, being able to share with your stakeholders that everything's not always perfect, that we've got a setback, we've got challenges. These challenges resulted in these learnings. Sometimes challenges resulted in closing programs, right? We said, hey, we are not able to, in the time we've got, with the resources we have, with all the focus that we need to provide, we're not able to succeed in the way that we seek to succeed in some of these programs. So we're going to shelf that for now. We'll, capture some lessons learned, and we may revisit that in the future, but you can't do everything.
Now, providers in particular are not great about closing programs. How did you make that happen? Because sometimes these things just kind of, trickle on. And I have to imagine that does help the case for intentional innovation, because people see that, hey, if this isn't working, it finally does get closed.
Yeah.
So how did you make that happen in practice?
I would tell you that the leadership that I worked for at both Humana and HCA all had such a financial and operations focused background that if you said, we're not seeing our return on investment, we can apply these resources, both human capital and financial CapEx, OpEx, and other places more effectively to a greater outcome, it didn't usually take a lot of convincing. It was, okay, you've checked this, is this something that you strongly support? And, you've got your reasons why, and you've got your key stakeholders in alignment with you, right? And if your clinical stakeholders are saying the same thing, like, yeah, we had really hoped this would be a game changer, but it wasn't, then, okay, move on. Like, that's really what I think the best innovators do, is they don't, every program or product that's developed is not going to be a winner. And, you need to be able to support those that are winners with the right resources, and to, wind down those programs, and to learn what you can from winding down those programs, but to wind them down nonetheless.
Mm-hmm. And you have mentioned several times throughout this the importance of communication. You mentioned a couple minutes ago internal marketing. How often did you go back to your stakeholders? Did you develop a routine process? Was it quarterly, in terms of, a readout in terms of what you were doing? Because that seems to have helped. And you mentioned doing that both with, your co-developers, your clinicians, and your even your patients. Can you talk about that a little bit?
Sure. Large organizations have a lot of those recurring touch bases already, like monthly operating reports and quarterly operating reports, and semi-annual and annual reports to senior leadership. So very fortunate that, from a senior leadership level, from the executive leadership team, there were those built-in opportunities to update the CEO, CFO, and so forth across the organization. What I would tell you is that we focused on, across the divisions. Humana has 15 divisions across all of its hospitals nationally. And those divisions are a combination of, let's say, an average of 15 hospitals, plus the urgent cares and the other outpatient ambulatory practices and surgery centers that operate in those geographies. And each of them is led by a division president and a leadership team at the division. And one of the things that the telehealth team did very effectively was to have quarterly visits when possible, and otherwise to have those quarterly updates through a Teams meeting, and to really be able to say, hey, this is where we're succeeding. We want to give you an update on these things. These are where we're having challenges. And some of those challenges were adoption challenges or bureaucracy challenges, and really being able to address those to maintain that, as you said, that internal marketing really translates to effective communication.
That's great. And I think you said Humana, but I think you meant HCA.
Oh, I did. Yeah, I meant HCA for the 15 divisions. Yes, sir.
And one last question, unless there was anything else you wanted to add, and this is a question that's just occurred to me a little bit. I was recently reading an article about AI in the military, and there's always been, with your background in the military and in healthcare, a lot of people have continued to compare healthcare to kind of retail and finance when they talk about the use of technology. And to me, it's more of a comparison maybe to the military, in the way that the military has had to resize and rethink operations, be more nimble and more flexible. And, part of this article is making the point with AI that with the military, if you make a mistake on coordinates or something, and a bomb hits the wrong place, people die. And I'm thinking the same thing with AI and an algorithm for a disease or an operation. And just wondering if you agree with that statement, or any thoughts on that.
Yeah, I think that having built a number of programs that are what I would characterize as clinical decision support, which is branching logic, and it doesn't approach the level of AI. I would say that in patient care, and I think lots of us are cautiously optimistic on being able to make sure that that bar is a very high bar on where we take our hand off the wheel, if you will, as those provider organizations, the clinicians, on that AI developing care protocol that is acted on without being checked at multiple other levels. And to your point, that's one of the things that, regardless of AI and coordinates in the military, there's a lot of quality assurance that occurs when you're developing programs and systems to make sure, and it's not fail safe, but it is developed to ensure that that we're not solving for an N of one, that we're taking into consideration that there are lots of other factors, environmental factors. Solving for one thing in one environment is not necessarily the same as solving for one thing in another environment. And so I think that translates. I may have gotten a little bit off where you were thinking, but
I think perfect.
I'm really so excited about AI as that enhancement, that the same way as I thought about it when we built the member summary, which is a payer-based health record back in 2011 at Humana. And we were able to help millions of member patients on an annual basis have their physicians really understand, we kind of in shorthand called it, a Carfax for a patient, because it prioritized where the most areas of greatest need were for those patients. If it was cardiovascular, if it was, being able to get an annual screening that hadn't been done, that was actionable. And so really creating those actionable information at point of care platforms, whether that's AI or it's something like we developed, 13 years ago, that really is an elegant branching logic, but it's an aggregator of data that sorts that data based on the priorities of the provider and the need of the patient.
Yeah, no, I think, your background is strategy and operations, and I think you've given an excellent example. To me, I think there's a lot of runway for AI to be used kind of in the front office, so to speak, to be looking at gaps in care, to be improving patient experience and things before you even get to some of those more higher risk clinical spaces.
Yeah, I think we're just scratching the surface. It's exciting, and it's also dangerous. So, I hope that we put the right quality assurance in place consistently to make sure that we're not overstepping.
Yeah, I agree with you. Anything else you wanted to add before we wrap up?
I've really enjoyed it. No, I think that we've covered a lot of ground. I am grateful for the opportunity to speak with you this morning, and I look forward to talking with you again soon.
Well, thank you very much, Christopher. I really appreciate your time, and it's been fascinating, and I always enjoy our discussions.
Me too. Thanks, Jeff.
Thank
Take
you.
care.
Take care. So with that, I will just proceed to wrap up our discussion. As I said, this podcast is in part sponsored by Healthcare Strategy Bullpen. We help providers adapt and deploy healthcare technology to improve the lives of patients. We help health tech innovators be more effective in deploying and developing their technology within the healthcare ecosystem. And we focus on 4 areas: operationalizing data to maximize its analytical value, demonstrating the benefits of new applications enabled by digital technology, applying digital health to high cost and chronic conditions, and also gauging and managing the practical, cultural, and technological issues around the social determinants of health. Please check out our latest blog, which is called Cutting the Administrative and Operational Burden in Healthcare with AI Lessons Learned, kind of what we were talking about there with Christopher, kind of the front end applications where I think this AI could be used. Please follow us on LinkedIn or Twitter/X. You can follow us on LinkedIn at healthcarebullpen.com or Diagnosing Healthtech, on Twitter at healthcarepen. Please subscribe to our blog and Diagnosing Healthtech. Our show is also sponsored by Redox. Redox is the leading source and destination of agnostic healthcare integration platform. Redox provides providers, payers, and digital health organizations with the strongest data foundation for shifting to digital health first for value-based healthcare. Be sure to subscribe to Diagnosing Healthtech on any podcast platform or scan the QR code to get updates. We will be taking a little break to enjoy time off for the summer, and we'll be back with a new format sometime probably late September. From all of us at Diagnosing Healthtech, thank you very much for watching and enjoy the rest of the summer.